Yeah, thank you very much, Peter, and thank you for the invitation. And yes, that's correct. I was supposed to, or I am supposed to talk about how to treat a patient when topical treatment is not appropriate. But I try to add in and when, because I think that's actually what I'll allude a little bit more to, that time seems to matter in these patients. So that's at least a discussion I would like to have. We don't have too many data to support that, but I think it's worth discussing. So these are my disclosures. I'll start out with a patient case, actually, and this is one of my patients. He started out in 1996 with mild psoriasis, and he was treated, as we heard from Nijip, with topical corticosteroids. Then he had increase in his disease activity. He was transferred to narrowband UVB. It was in a private practice. He was treated like this, and then he got mild PSA. Methotrexate was introduced because also he had a PASI at that time of 19. He was well controlled for many years, but then he had an increase in his liver enzymes, and methotrexate was stopped, and he was referred to our department. And this was the pictures at the bottom, was what he looked like in 2017 when he came. And at that time, we started him on a biologic treatment. And I actually think that this journey Peter has been on is probably the journey that most patients are on. And this is when we use this treatment algorithm, the usual step-up treatment, you could call it. And this is where we go from the topical treatment that we have nicely heard about in the previous presentations to the systemic drugs. And I'm not going to give an algorithm for the use of systemic drugs because it should be used in an individual manner. And of course, it also depends on the clinical situation that you are working in. We know that there are huge differences around the world. So what we have here is the systemics that are available. We have the so-called maybe older small molecules, the cyclosporin, the methotrexate, the acitretin. They are older, but they are still worth considering, and we use them a lot in my department still. And then we have the biologics and the novel small molecules. And just to let you know what I mean by the biologics and the novel small molecules, I have this very busy slide. Don't be confused. I'll try to explain it. It's just from a review paper that we made last year on small molecules. And the thing is that the small molecules, they act inside the cell, which is opposite to the biologics that usually target either receptors on the cell surface or the ligand for the receptors. So when I talk about the novel small molecules, I tend to think about, see if this pointer works here, the fumaric acid esters down here. They are available in some countries, not all countries, I know that. We have the PDE4 inhibitors, apremilast we know of. It's a novel small molecule. And then we have the JAK inhibitors. They are more used in atopic dermatitis. I know that we have some in arthritis, but soon we'll have at least probably deucravacitinib that targets TYK2. And this is a signaling molecule that belongs to the JAK family. And then we have highlighted some other targets that are under investigation. But these are the small molecules that we also have in our armamentarium, at least in some clinical settings. And we have the biologics, and we know of them. We have the family of TNF-alpha inhibitors. We have the IL-12/23 inhibitor. We have the IL-17 targeting drugs. And there are differences in this group because we have secukinumab, ixekizumab that targets IL-17A. Brodalumab has a different mode of action. It targets the receptor for IL-17A, the IL-17 receptor A. And then we have the most recently launched drug, bimekizumab, that targets both A and F. And then we have a group of biologics targeting IL-23. And it's difficult to give priority to one drug or another. But one way, of course, or something that we should consider is that, do the patient have psoriatic arthritis? That makes a difference because some of the drugs are having the indication of psoriatic arthritis. So that makes a difference. Also, we have to look at the comorbidity or associated disease profile of the patient. We know that IL-17 targeting drugs are probably not the drug of choice if we have a patient with active inflammatory bowel diseases. So these perspectives has to come into play when we have to choose. And of course, we can also look at the efficacy. But in general, I would say most of, at least the biologics, but also many small molecules, including methotrexate, they are very efficacious in some patient. And of course, we don't have head-to-head trials, so it's extremely difficult, and we have to be extremely careful when we compare one drug with another if it hasn't been studied in a head-to-head trial. But this is a network meta-analysis that was conducted some years ago, and here you can see this is the 90% PASI improvement in gray, or the 100% PASI improvement, complete skin clearance in blue, and you can see that at least some of the recently launched drug over here, IL-17 and IL-23 targeting drugs, on the short term, 10 to 16 weeks, are extremely efficacious. And it looks like that some of the other drugs tend to catch up over time. So we have, what I'm using this slide for is not to give priority to one biologic over another, but just to say we have in our armamentarium extremely powerful drugs if we move to systemic treatment. But if we look at Peter, he was on his journey for more than 20 years before he was at least put on the biologics, but he was on the journey for more than 10 years before he was put on a systemic treatment. And I think that's the experience we have, most of us, when we look into our patients. So the obvious question is Peter's psoriasis different in 2017 compared to what it was in 1996? And I see some of you knocking, and I think that we don't really have the data to support that, but I think we have the clinical experience that it's so much easier to treat a patient with first appearance of psoriasis than a very chronic patient with psoriasis, like in this case, 20 years. So it looks like that there is a difference in the psoriasis over time. And that's the reason why we talk about some people don't like disease modification, and maybe it's not a proper wording, but it's being discussed whether we can do something by early intervention, because it looks like the disease is changing. Maybe we cannot modify the disease, but we can more easily treat that. We don't have many data on that in psoriasis. Luckily, we have 2 trials ongoing that will hopefully help us address this. This is the STEP-IN trial and the GUIDE trial, but the data has not been made public yet. But in the coming years, we will learn more about that. But we can look to our colleagues in other inflammatory diseases like rheumatoid arthritis and Crohn's disease. They have studied that in much more details than what we have in dermatology, so far at least. And I'm not going to go through the results, but I have listed the papers, and there are many more papers than those that I have listed here. You can look them up yourself, but you have to believe me. The conclusion from these studies is that early intervention makes a difference in rheumatoid arthritis and in Crohn's disease on the long-term outcome of these diseases. And intensive and effective treatment are extremely important, and deep remission. And that's probably the key. I think this is the key slide for our discussion today. And that's the reason why I believe that the new classification by the IPC is so extremely important, because with the new classification, we should move to more intensive and effective treatment if the patient is not treated satisfactorily, instead of waiting until the PASI or the BSA reach a certain limit. So to achieve this goal, to be allowed to use early intervention, to get deep remission and intensive and effective treatment, we can use the IPC classification of the disease severity, and that's where I think it's extremely important to adapt to this classification. As I said, we don't have many data on that in dermatology, and this is not a proof of anything, but this is an indication. This was from a poster at the last EADV last year. They looked at the baseline demographic and clinic characteristic of patients that reached an absolute PASI of 0, and then they compared to the comparator group, and that was a post hoc analysis of the Voyage 1 trial. They looked at patients that had a PASI of 0, complete skin clearance, throughout 156 consecutive weeks. And what came out was that there was a difference in the disease duration between the 2 groups indicating at least that if you intervene earlier, it may be more efficacious. You may get a better clinical outcome. There was another poster at the same time, and here they looked at the duration of psoriasis, whether it was a predictive factor for loss of response to a biologic. And again, the same observation was made that the shorter disease duration you had, the better was the outcome of the biologic. I fully acknowledge it's not a proof of that we have proven that it makes a difference, but it's a strong indication at least, and it adds to the experiences that we've seen in Crohn's disease and rheumatoid arthritis. And then the last study I want to highlight is from the Stockholm psoriasis cohort. Here patients were enrolled within the first 12 months after they were diagnosed with psoriasis. And that was going on in between 2001 and 2005. And then they were examined by a dermatologist 10 years after. And as you can see on this graph here, see where I have my pointer here, you can see that those that were on a systemic treatment at or before enrollment in the trial, they actually had less severe disease 10 years after compared to those that were treated with a systemic treatment in the last third of the follow-up period within the last 3 years. Another strong indication that we should be ambitious, we should get deep remission, we should get effective treatment, and we should move on if we cannot be successful with the treatment that we have initiated. And this actually leads to my last slide. I think the key is, when should we introduce the systemic? And I think we should be ambitious, but I think we also should, and I think Nijab said that we should not necessarily stick to one treatment. We should remember that we can combine it. This is not an algorithm that you move from a topical treatment to a systemic treatment, but we should remember that we can use the combination. Sometimes we can use methotrexate in combination with a topical treatment to achieve the goals that we are aiming for. And the goal is to get disease control very early on in the disease course and get deep remission. I think that should be the take-home message. So with this, thank you for your attention.
Thank you very much, Lars. Thank you very much. Leandro.
So, thank you for the presentation, Professor. When you see the studies related to cardiovascular risk, you see that patients which develop the disease earlier in the life, younger patients would have higher cardiovascular risk. So as you talk about disease modification, when you start systemic treatment, would you also think about reducing the cardiovascular risk in that patient, thinking as a systemic inflammatory disease?
It's absolutely a very relevant question. And my answer would be yes, I would think of that. We have data, and we have also published from my group data indicating that you can, this is indicating because you have to have a long-term follow-up to show the hard outcome, to see the cardiovascular events. So it's more when you do the imaging of the vascular inflammation. We have done that, others have done that, and indicated that intervening and getting disease control would limit the degree of vascular inflammation, and that's a surrogate marker, indirect marker of avoiding a later cardiovascular event. I should say that there are also other publications that questions this, so it's not a fixed given thing yet. So this is something that is still being studied. But you asked for my opinion, and yes, I do still believe that getting disease control is not only beneficial for the DLQI of the patient, for the skin of the patient, but also for some of the associated diseases or comorbidities. Yeah.
One short question by Arnon, and then we have to move to the panel discussion. Yes.
Professor Iversen. Very nice presentations always. A few years ago, you spoke about early intervention to prevent a scar in the skin that will enhance the severity of psoriasis. So are there any studies going on now that you know about early intervention?
Yeah, there are two studies. The GUIDE study with guselkumab, the Janssen study, and then the step-in study with secukinumab. And they are, at least I know for the step-in study, it has stopped the recruitment because it has been completed. So we will get results from these studies, and they are doing molecular studies as well to look at some of those cells that the tissue-resident memory cells are one cell type that we believe play a role in this molecular scar, but we don't have the result yet.
Okay. Thank you so much, Lars.